All right, I'll go ahead and get us started today. So hello and welcome to Grand Rounds for the Minnesota Regional Spinal Cord Injury Model Systems, or MINSCIMS as we call it for short. We want to thank you all for joining us today. MINSCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDILRR, to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injury. Next slide, please. MINSCIMS represents an exciting partnership among the following Minnesota institutions: Courage Kenny Rehabilitation Institute in Minneapolis, Mayo Clinic in Rochester, Regions Hospital in St. Paul, and the University of Minnesota in Minneapolis. Next slide. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, the Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical, acute care, acute rehabilitation, and post-acute services. My name is Kimberly Mondin, and I will be the moderator for today's session. I'm an assistant professor in the Department of Rehabilitation Medicine at the University of Minnesota Medical School and co-project director of the MINSCIMS with Dr. Leslie Morse. So next slide. A few housekeeping notes to begin. The University of Minnesota has organized the CME for today's webinar. Please see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. This meeting is being recorded and will be posted on our website. To earn CME credit for today's presentation, please click on the link in the chat. Due to the number of registrants for today's webinar, we have placed phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the chat and Q&A functions. If you have technical or logistical questions, we ask that you submit those in the chat to Dan Kelly. And we also want to thank Dan Kelly at the University of Minnesota, who works behind the scenes to make these webinars possible. Next slide. The title of today's presentation is Advancing Health Equity, Actionable Strategies to Building Trust. And our speaker for today's webinar is Dr. Stephen Jackson. Dr. Jackson is a physical medicine and rehabilitation doctor and the medical director of patient experience at Regions Hospital in St. Paul, Minnesota. He is committed to ensuring every patient receives the care they need. Dr. Jackson believes cultural humility and a shared curiosity about our differences are key to building stronger communities. Dr. Jackson is the clinical program director of spinal cord injury medicine at Regions Hospital and an adjunct assistant professor in the Department of Rehab Med at UMN. He is also the co-chairman and medical advisor for health equity and the medical director of patient experience at Regions Hospital. He has led several research projects in SCI, including a current award through the Minnesota Office of Higher Education to investigate the effect of exercise on chronic inflammation in SCI. Dr. Jackson, welcome and thank you for presenting. And I will hand it over to you.
All right, Kim, thank you. And thanks everybody who are in attendance this morning. Let me just make sure things are gonna go well. All right, I have no conflicts of interest, nothing to disclose, and we will get started. I'd like to start off with this slide because this is kind of who we are in terms of those that are affiliated with HealthPartners / Regions Hospital. And some of the key words that I've taken the liberty of highlighting will be ones that we will refer back to, including trust and relationships built on trust and compassion and those kinds of words, even partnership, to kind of ground us. And so today we will be talking about trust. We'll be talking about actionable strategies for building it. The reason I say actionable is because sometimes the concept of trust, it's pretty, it's pretty nebulous. It's pretty intangible. What is trust? How do you build it? When is it broken? And so we're going to try to talk about some things that, we can consider going forward when we think about building trust, not only with patients and families, but with also our colleagues. So I want to start off with a patient story to kind of get us going. This is a 30-year-old African-American female who happens to be 8 months pregnant. And on this particular day, she was at her baby shower. Very exciting time for her. And raised in poverty and had a lot of challenges kind of growing up personally. And didn't even know that she was going to be able to have children. And here she is getting ready to give birth. And this was a very happy occasion for her. She worked in healthcare. She was what we call at Regions a HUC, or basically a unit clerk. And so she was always around, medical folks, doctors, nurses, the like. And at this particular time, during this party, a cardiologist who was very well known in the hospital that she worked at walked up to her and asked her pretty confidently, pretty boldly, "You're really going to have that baby, aren't you?" And she was kind of caught off guard because she couldn't really believe what she was hearing, being 8 months pregnant and all. And so he repeated, "You're really going to have that baby, aren't you?" He said, "You could have had an abortion." I know that's a hot button topic. And so she replied, kind of out of a reaction, and said, "Well, so could your mother." She was pretty quick-tongued. Needless to say, that ruined the relationship that she had with this physician that she worked with, or worked near, should I say. And not only that, but it sort of hurt in some indirect way her trust, not only in medical personnel, but in healthcare in general. And by the way, mom and baby are fine, although both mom and baby have a lot more gray than this picture shows. With that being said, we're gonna dive into trust. And the interesting thing about trust is this: we often say that it's easily broken and hard to build. And Merriam-Webster says that trust is a confident belief in someone or something, an assured reliance on the character, ability, strength, or truth of someone or something. And the interesting thing about trust, and the principle that we're going to be highlighting throughout the talk, is a simple one. It's that you can have all the letters of the alphabet behind your name, and it doesn't mean that patients or colleagues, for that matter, will automatically trust you because you are competent and you are a nice person. People have lived experiences that affect their trust in a lot of things, including healthcare. And you may have a young lady that comes to your office, and you might be well-intended, but they may not trust you because they had a bad experience. And so we're going to talk about those principles. And we're going to talk about perhaps some solutions or ways to think about building trust going forward. So one of the first principles is, in every interaction you decrease or decrease trust, whether you know it or not. That trust meter is going to go up or go down with every interaction. And here's the second principle. And this kind of speaks to, folks being well-intended and being very competent. Maya Angelou said that I've learned that people forget what you said, they will forget what you did. Because particularly as physicians and healthcare providers, we say a lot and we do a lot because we're trained to say and do a lot, right? But people will never forget how you made them feel. And that's just as, if not more, important. So I like to have this slide up here. And I have it entitled My Profile. Yet another older picture. This one not with much gray at all. When I first started at HealthPartners, look how happy I was. That's a joke, everybody. So my profile, I have yes, maybe, and no. And this basically represents what we may or may not know about the people that we interact with. So whether in a healthcare setting or otherwise. So yes, you'll probably guess right that I'm African-American, male, and short, although short is in the eye of the beholder. Maybe. You might see a ring on my finger and maybe assume that I'm a husband or I'm a significant other or somebody's significant other. You may see pictures of my kids and assume I'm a father. You may see a white coat, or you may see a name tag and assume that I'm a doctor, perhaps. But the things that you probably don't know are my long list of good and maybe bad experiences, my victories and defeats, my struggles, my fears, my biases, my hopes and dreams. And this is when it gets a little dicey, because people come to your office or they come to the hospital or you interact with them in public. And there are a lot of things that you can be pretty sure about when it comes to them. But that no category, as you can see, is a lot longer than the yes and the maybe category. And this is what and who comes to the clinic and to the hospital for care and treatment. And we have to keep that in mind moving forward. And it sort of adds to the awkward dance of patient and clinician, sometimes clinician and clinician, or colleague and colleague. And extra points for anybody that can type into the chat what movie this is. Pretty classic comedy. So where have we been? Where did this whole trust thing start? Or what are some of the early things that maybe contributed to this lack of trust? So many of you may be aware of the Tuskegee experiment, which took place somewhere in the probably ended around the 1970s or so. But basically, for those that don't know, I'll give a quick synopsis. There was an advertisement for treatment of syphilis. But what ended up happening over the course of 40 years is that people were sort of used for folks to note the natural progression of syphilis when not treated. So stage 1, 2, stage 3, and 4, et cetera. And people went untreated for 40 years. And so, to make a long story short, people, particularly people of color, were experimented on. And this, amongst other incidents that I won't be talking about, contributed to widespread mistrust of healthcare, especially with regards to people of color. I have people in my family that do not go to the doctor unless it hurts so bad that they can't breathe. In fact, their primary doctors are emergency medicine doctors, because that's when they actually go in, when it's an emergency. And this is just one reason why that is. Other lived experiences also contribute to that. When we think about trust, make no mistake about it. The things that are happening in our world and in our society affect that relationship. It affects that process whereby we build trust with others. Now, you may not have anything to do with any of these pictures here. You may not have, issues, quote unquote, when it comes to race or bias, although I think we all have biases. But the point being, when people come to the office, they're not just bringing their diagnosis. They're not just bringing their chief complaint, but they're bringing those experiences. They're bringing maybe what they read and heard on the news, or maybe a bad look or a bad experience that they had earlier in that day. And this is what we have to be cognizant of, because that very thing might affect the relationship that you're trying to build with the person that you're serving. Where are we? Well, just like we had a historic context, the same things are happening today. Whether protests, to civil unrest, to anger, to injustice, to a lot of things. There are things that might not be directly linked to healthcare that affect healthcare and affect our ability and our goal of building trust with those that we serve. And then if you add a pandemic and you add a vaccine and you add fear and the distrust that's already there, now you have another problem. And so there are a lot of things that have happened in the past and a lot of things that are happening in the present that affect trust, the very thing that we need to build in order to get the outcomes that we want to attain, which we'll talk about. What do we do know? These are just a few statistics that highlight the healthcare disparities that are in our world. we may not know exactly why there is mistrust. Again, it can be anything from what you heard growing up to personal lived experiences to, knowing history. But there are obviously healthcare disparities, and this is just a few. And the disparities aren't just limited to race, but these are the ones that I included in this talk. And again, we may not know exactly the why. There's a lot of conversation and talk and research regarding social determinants of health. I'll give you a prime example. We have a patient story that we present in different venues here at Regents Hospital when it talks about having an outward mindset. And there was a patient who was labeled as non-compliant because they would miss certain very important doctor's appointments, let's just say. And after, being more curious, we realized that this person needed to pay for food. And so it was either come in for an appointment where you pay for transportation, maybe pay a copay, or is it pay for food? And they chose pay for food, and they were, viewed as non-compliant until, there was more to be learned. And so there are a lot of reasons why people may or may not show up. They may show up with an attitude. They may show up with a lot of things going on, and it may predate us, and it may not have anything, to do with us, but still we have to kind of fight through a lot of the noise and barriers to build trust, because it's what we all need to get to where we want to be. So where do we go from here? So I want to introduce the trust model. And this is something, again, that is not exhaustive. I believe that there are many aspects of trust that many of you listening can contribute to and talk about. But I feel like it's something that's pretty practical. And what I like about it is that it's applicable universally, but definitely it's applicable to healthcare. In healthcare, we often talk about how much time we don't have, and I'm one of those. But what I have learned is that patients and families alike appreciate the time that we take to explain things and to go over things and to answer questions and to ask, do you have any other questions, or is there anything else that we need to talk about? When you're in a clinic and you have a lot of patients and you have patients waiting, or maybe you got to clinic late, or there are other things going on, whatever the case may be, time is of the premium. But time goes a long way in building trust, because what you do, you send the message that during the time that we have together, you are very important, and I am willing to spend whatever time I need to get to the chief issue that you're here for. When it comes to relationship, I think relationship is important, and I don't advocate that we pass out our social security numbers and tell all our deepest secrets to our colleagues and patients alike. But at the same time, the principle of relationship here is that it sends a message. When you build something with another person that's outside of, say, just the diagnosis, even if you're inquiring about their family or inquiring about how their day is outside of the blood pressure or the spine injury, then you're sending the message that you are more than just a diagnosis and a treatment plan. You are a person. Again, going back to that long list of no's in that profile slide, you are a person with hopes and dreams, aspirations, family, fears, biases. So when you ask about family, or when you take the time to build a relationship beyond the diagnosis, I believe that goes a long way. And I have so many experiences that I can share with regards to that. In terms of understanding, when people come to our offices, again, there's a long list of things that we don't know about those that come to the office. And although I'm not a big proponent on cultural competence more so than cultural humility, I think it is important to know a little bit about our patients so that we can better serve them. I'll give you an example. There was a patient who was of the Muslim faith tradition, who for a couple of days when she first got to the unit, I would sort of reach my hand out to show, kind of shake your hand, say good morning or good evening, whatever the case is. And she would kindly pull her hand back. And it sort of hit me that there's something going on here. Because I don't think she's being rude, but there's something that I'm missing. And so what I found out, and maybe not in all cases, because I don't want to generalize here, but I did find out that in some cases, if I'm not the husband or the brother of a young lady, then they don't want to touch the hand of another guy. And I'm probably stating it simply and ignorantly. I apologize for that. But the point was, in gaining that understanding, I learned what was more comfortable and more acceptable to her being my patient. And so in the subsequent times of visiting her at the ward, I would kindly clasp my hands and sort of kind of nod and kind of say good morning. And over time, there was a noticeable relaxation that would come over her face. It's almost like he's not going to reach for my hand today, or he sees me as more than just a diagnosis. And I'm a big proponent of finding out about your patients. Again, I'm not an expert in her faith. I'm not an expert in a lot of things, but I am an expert in listening and hopefully picking up on what the mood of the room is and kind of what direction we are going and where we need to go. And I think that bought me some currency, some trust currency, because over time, she opened up, and it became a little bit more than just a spinal cord injury, but it was more about, living life and life beyond the injury and family and those kinds of things, where before, it was, she was noticeably very guarded and I'm sure fearful with everything going on. So understanding is a big principle as it relates to building trust. And I encourage you all to, in all you're getting, get an understanding, because there may be more than just meets the eye, and it may not be personal. When she pulled her hand back, it wasn't personal, but it was where she was coming from. And I think it's important for us to at least have an idea of where our folks are coming from so we can best serve them. Sacrifice. Sacrifice speaks to being willing to go the extra mile, whether again, that's time, whether that's, again, taking the time to know more, taking the time to build a connection that can go a long way, or again, doing maybe the unexpected or doing more than what is expected, simply to build trust and to earn the trust of the people that we serve. I'll give another example. There was a patient on the rehab unit here at Regions some years back who was of the Jewish tradition, and they didn't want to use the microwaves on the unit. And now, as a team, we could have taken the stance of, well, these are the only microwaves we have. I'm sorry, there's nothing else we can tell you. And what our nurse manager did at the time, she found a brand new microwave and provided it for the patient and his family and labeled it and said, this is for so-and-so in room, whatever the number was. And did she have to do that technically? She didn't. But it sent the message that I care about you as a person. I care about what's important to you. And that's the central principle when it comes to building trust. Because after incidents and events like that, I would imagine that the patient and family looks at this like, this is somebody who cares about me as a person. And that's very important going forward when it comes to when we use the word compliant, being compliant with medication or being compliant with a treatment plan. I may not totally understand the treatment plan. I may not totally agree with it because it doesn't line up with what I read on Google, right? But I trust you because I know you care about me as a person, not just my diagnosis. And that's just one example. And finally, thinking outwardly is actively and intentionally putting yourself in the position of the people that you serve. Another word for it is empathy. And that's another talk in and of itself, but that's a trust model in a nutshell. Well, what do we know about trust, and why am I talking so much about trust? Is trust, is it really as important as I said? Well, in a study that really stands out in my mind that I wanted to include was that trust was associated with two main things in this particular study: interpersonal competence. How am I on time? I'm okay. Okay. Interpersonal competence and technical competence. So here at HealthPartners, we have a motto. It's called Head and Heart Together. And this study kind of outlines or highlights that, or at least reminds me of our motto here at HealthPartners, because it's saying that in order to build trust, you can't just be competent technically. You can't just know your stuff as a spinal cord doc or a spinal cord nurse, et cetera. But you need to also couple that technical competence with interpersonal competence. You need to be able to make that time, or be willing to take time to listen, show empathy, be honest, because one without the other is incomplete. And so you can't just be the person that, again, knows all the facts, but you don't know how to relate. And then vice versa, you can't be the person that's very empathetic and very caring and spending the necessary time, but you're arriving to the wrong diagnosis and treatment. So there has to be both things, and trust was associated with both, again, interpersonal competence as well as technical competence. And in this particular study, distrust was associated with this list of things as well. Again, real or perceived racism, experimentation, and other things. Again, real or perceived. Maya Angelou said it, how a person is made to feel, whether real or perceived. And those are very things that we have to keep in mind, because it can affect how things go in the relationship as well as the outcomes. Speaking of outcomes, what are the consequences of trust? Honesty with physicians. Of course, you want people to be honest with you when you're treating them. Of course, you want them to be compliant with treatment and follow-up recommendations. After all, you've probably gone to school for 60 years. You want to put those treatment plans to good use, right? But what about distrust? Well, when there's distrust, some people forego care altogether. They refuse indicated treatment. They might not seek care in the first place. They may go from clinician to clinician, which is not a very good thing. And so there are outcomes that we may or may not arrive to because there's distrust. So what am I saying here today? Am I saying that we should give special preference to people? Not necessarily. Am I saying that we should be 60 minutes behind in clinic every day just so we can make sure people have enough time to spend with us? Not necessarily. Give me an example. I have these glasses up here. I happen to wear glasses for those that are looking at me. If you were to sit me in a standardized test, and let's say it's 20 other people, and we've all had, let's just say, the same amount of preparation, the same amount of exposure to the material, and then the examiner says, okay, I need everybody to remove their glasses if they're wearing them, because I want to make sure that the playing field is level. I want you to know that I would not do very well on that test because I need my accommodation. It's not until the glasses are on that the playing field is truly level, right? In a similar sense, I thought this was pretty funny. For a fair selection, everybody has to take the same exam. Please climb that tree. I think this is hilarious because how often does this happen in our real world? And obviously, looking at this, maybe one of these animals would be able to do that, right? Okay, so I want to introduce the principle of equality versus equity. And equality and equity principles aren't just related to race, but also gender, orientation, and ability, and you name it, equality and equity applies. And the principle is giving people what it is that they need so they can be equally successful, or at least have an equal chance to be successful in that given context. So going back to the example that I gave, if I were to take a test without my glasses, although everybody in the room were quote unquote equal, meaning no glasses, I would do very poorly because I didn't have the thing that I needed to be just as successful as a person who didn't need glasses. So that's the principle of equity, is that when we treat patients, we have to make sure that we are doing what we are doing as much as possible to give them what they need to be successful. I had a patient who I was trying to get to be our discussant who was not available, but I was doing, or going to do an Asia exam, and many on the call probably know what an Asia exam is. She was female, and she was noticeably uncomfortable when I talked about the exam. I happened to have a resident who was also female. She was a senior resident. She's very good, very, very competent, et cetera. And what I did the scribing, and I sat behind a curtain while she performed the exam, and she called out the levels and told me, 4 out of 5 strength or 1 out of 2, sensation, et cetera. Pretty unorthodox, pretty non-traditional way to do an Asia exam. But because she had been training with me, for the better part of a couple months, I knew that she was more than capable, but I also knew what this patient needed to feel comfortable, but also for me to still get the job done. That's just one example of equity. And it's definitely different from equality. And when building trust, it might be important to consider the concept of equity, because some patients may need something different than the traditional things that we provide. And being creative and being willing to listen and be curious will go a long way in building trust. So some of you may say, well, I just want to treat people, or I just want to do my job and get home, or do my job and stay sane given the circumstances that we find ourselves in with the pandemic and being exceedingly busy and everything else has been going on. There are truly challenges to connection, whether fatigue or impaired resilience, and you guys see it, our tanks are likely on empty or close to it. And it's tough to sometimes think about some of these principles, especially when we feel the way we feel, or maybe perhaps experience some of the things that we've experienced over the past 2+ years. Nevertheless, our patients are speaking to us. This is a summary from the data that we got from patient surveys, particularly here at Regions. And these are the 4 principles that were highlighted. And this is what was important. Someone cared about me. I could trust them. I received consistent information. Someone listened to me. So even with the challenges that we might be having as a care team, patients are still saying, I want somebody to care about me. I want somebody that I can trust. I want consistent information and someone listened to me. In fact, when we look at how our patient experience scores here correlated with some of the principles that we extracted from the surveys, we saw clearly that the highest correlate was staff cared about me as a person. So again, it highlights the principle that we've already been discussing here, that it's not just enough to be competent and ready to treat and diagnose, but people care about how you make them feel, unintentionally or intentionally. That matters, and it correlates with what they're saying back to us. So regardless of our background, where we come from, how we were raised, all of those things affect the filters that we apply to situations, medical and non-medical. And we all have filters, whether we care to admit it or not, we all have a filter, okay? But regardless of that filter, people generally want similar things, whether you're a patient or not, whether you're a care provider or not, regardless of your demographic. People want to be known, respected, protected, and supported. And in building trust, those are usually resultant of building trust. this clinician or this person knows me as a person. They respect me and what I believe. They respect and they care about what I care about, what I value. Even if it's not their personal value, they care about it. And another gold star, if somebody wants to chat in what movie this is. It's going to take all of us. You know, I asked the question, whose job is it anyway? You know, when we think about these principles of trust and we think about things like diversity and inclusion and equity, is it the job of legal and HR and the D&I team? Or is it the job of the whole organization? And, you know, depending on where you are or where your organization is, maybe these things that I'm talking about, it's limited to the D&I team. And maybe it's HR. We have to do a training. Let me do my training and finish clicking so I can get on to other things. But I challenge you, not only as a system, but as an individual, to evolve. It's work for all of us. Because when we do our part in making sure that everybody has an equal chance to be successful, then that's when we can move that proverbial needle. I challenge you, and I want to submit today that it's the job of the whole organization to make sure that people get what they need so they can be healthy, mentally, physically, spiritually, emotionally healthy. And we play a big role in that. Well, some of you might say, well, you know, I'm not a subject matter expert when it comes to equity. Some of these principles are brand new with this talk. Well, Martin Luther King said it best. He said, well, if you can't fly, run. If you can't run, walk. If you can't walk, crawl. But by all means, keep moving. In other words, wherever you are, whatever your knowledge base is when it comes to things like this, you still have a part to play. And it's a big part, and it's a very important part. So, after this talk, what role have we played as a healthcare community in increasing or decreasing trust? And after hearing this talk, what will you do differently going forward? So I hope that this was informative. I hope that some of the principles that we discussed today, you will seriously consider and maybe go to your quiet place or go to your confidant and have a very important conversation about any opportunities there are going forward and how we treat not only, you know, patients and families, but one another. Thank you.
Thank you, Dr. Jackson. If you want to go back to that other slide and keep those discussion questions open, I think that would be great.
Absolutely.
Thank you for an excellent and I think very necessary Grand Rounds presentation today. And thank you for your time. We now invite our participants to put their questions in the chat or the Q&A. We'll be monitoring both. And so yeah, please put your questions in for Dr. Jackson so that he can answer those. And if anyone wants to consider the questions that Dr. Jackson posed as well. So what role have we played as a healthcare community in increasing or decreasing trust? And after hearing this talk, what will you do differently going forward?
I encourage people to not be scared. It's okay.
Got a quiet group today. Oh, there's one in the Q&A. Oh, Ricardo said, excellent, thanks, talk. Excellent talk, thanks.
Thanks, Ricardo. Appreciate it, sir.
Someone said, Dr. Jackson, that was a great presentation. As a doctor, someone with limited time, when do you feel the best time to create that connection with patients?
Excellent question. I appreciate that question, anonymous attendee. So I'll go back to what I said before when it comes to that unknown quote. It says, in every interaction, you increase or decrease trust. So again, time is limited. I'll be the first to say, even being the person that gave this talk, time is limited and it can be pretty crazy in real time. No pun intended. With that being said, I feel like if we were to be intentional about making every interaction count, then that's the first step in building connection. I'll give you an example, quick example. I'm in Minnesota Viking and Green Bay Packer land. I'm from Chicago. I'm a big Bears fan. And, and again, I don't have a script. I don't have things written down in terms of what I'm going to say before I say it. But I'm always, again, intentional about making connection points with patients and families, not only because I like to do that, because I'm a very talkative, personable person, but at the same time, I do know the value in connecting with people on a level beyond the diagnosis, talking to people about everyday things. I think it puts people at ease, and it reminds them that not only are they people, but we are people as well. And so, example, I'll walk into a room, a person has on a Green Bay Packer shirt. I may say something like, I think we're going to have to cut this visit short. I know it's a 40-minute visit. We might have to do 10 minutes because I'm offended by that shirt, for example. And usually there's some kind of laugh or chuckle. We might talk a little about sports or what have you, but it almost breaks the ice. And that took me 5 seconds, So the whole point isn't necessarily the quantity of time, because I think for the most part, we all have limited quantities of time, but it's the quality of time that we spend and being intentional about what we use or how we use that time. And so in every interaction, make it count. On purpose, build a connection. Look for something that, you can highlight that makes that person unique. They're not just another number. They're not just another patient on the ward. They're not just another injury, but they're a person. And I think the more you do that, they'll see that. And I think it'll build trust currency. Thanks for the question.
Thank you, Dr. Jackson. Marty put a question in the Q&A here. What can we do as a team in our model systems to ensure this remains central in what we do and or what we impact or change?
That's a great question. Leave it up to Marty to ask me the hard ones. I'll see you later. I always tell people jokingly, but not jokingly, it's not real until I write it down. Because if I don't write it down, I might forget it, I might forget it. And so what I'll say to that is, going back to the previous question, we have to be intentional, and I'll underline it. I'll triple underline intentional. If we are serious about the concepts and practices of diversity, equity, inclusion to be important and more central, from a larger systemic standpoint, make it part of an annual plan. Make it part of, a system-wide goal, and then attach measurables to that. Similar to some of the things that we've done here at HealthPartners and continue to do. From a more, from a smaller scale, meaning our model system here, again, I know we have the connection with the equity and inclusion team or group. That's one way, that's an intentional way, but we can have a journal club. We can have a report out of experiences related to D&I. Like, hey, I had a patient who didn't trust me, and this is what happened, and we have a better relationship. There are ways to keep it central, but we have to be intentional about it. Those are just a few small examples. Of course, Marty, that's a pretty big question, and I would love to sit down and talk to you more about it, because I think we should think about how we can keep this central, because, our workforce and those that we serve, they're becoming more and more savvy, diverse in thought, et cetera. And we need to be ready so we can best serve those that we do serve. So hope that helps a little bit. Those interactions make such a, they do. They definitely do. All right. One question I had is about recruiting a more diverse patient population. Building trust requires getting patients. That's true. I've noticed as a surgical subspecialist that I see quite a homogeneous patient population. I want to see it's more diverse than the folks I see in the office. Do you have suggestions for connecting with other providers, getting into the community? Absolutely. I think the big key is community. Because here's the thing, one of the many reasons why there is distrust is that people feel like as care providers, we're not doing stuff with them, we're doing stuff to them. And sometimes, we can come off as people that are in the know, because to some degree we are. Again, we've been trained, we have the degrees, but sometimes people want to be quote unquote included in the plan, and they want their viewpoints to be considered when making that plan. And furthermore, I've learned that in connecting to community and connecting with community leaders who sometimes represent the population that we serve, it goes a long way. So getting a pulse of the people, getting a pulse of what's needed, what's not needed, what's desired, what's not desired, creating or shoring up any advisory councils that you may have. If you have a patient family advisory council, those can be very effective, just so that you're constantly getting the voice of those that you serve. Furthermore, I think actually, again, not only just connecting with community leaders and representatives, but going into the community, going into local churches and places of worship. But sometimes you have to go get people. Sometimes you have to show that, hey, I'm not scared, or, you have to do whatever it is that you need to do to eliminate any barriers between, I guess, care provider and those receiving the care. So again, these are really good questions, and they warrant longer conversation and discussion, which I'm more than willing to have. But those are just my initial thoughts to that.
Ricardo also made a comment that history matters, and would you reflect on how mistrust on the medical scientific establishments is unfortunately justified due to a long history of unethical treatment of disadvantaged populations? For instance, the Tuskegee studies, which you mentioned. Should we have a special seminar on this topic?
I think it's something that we can and should consider. Here's the interesting thing, Ricardo, about what you're saying. People feel like time heals all wounds, and that's not true. I don't think that's true at all. I think time can make make wounds, hardened, and sometimes time makes it harder to get to the core of that wound so that it can be healed. I apologize for that page. And thus, sometimes when we talk about diversity, equity, and inclusion, you get a various number of responses like, why are we talking about this at work? Or why are we still talking about this? Things are kind of quote unquote quiet. Like there aren't any, at least from what we can hear or tell, there aren't any George Floyds happening right now. Things for the most part have been a little quieter. Why we're still talking about this? Well, diversity, equity, and inclusion should be more than a department, and it should be more than a thing. It's life. It's a way of life. We are different people with different needs, different values, different lived experiences, and those things affect what we do as clinicians. And I think that's the centralized principle of that, including trust. And so having an open and honest discussion about the fact that, yeah, Tuskegee happened a long time ago, but it still affects people. I gave you the example of my family. And it's not just Tuskegee, it's also lived experience. And that's something that I think we should consider, navigating through, whether personally or as a group or as a system, et cetera. Because like the surgical subspecialist said, he doesn't see a lot of the people that's represented in his community. And there might be a good reason for that. And so being intentional about building trust is very important, Ricardo. Thank you for the question.
Yeah, and then Dr. Reeves thanks you for a fantastic talk and asks if you're aware of any organizations that have attempted to implement standardized staff training regarding behaviors or strategies that staff can use to create trust with patients.
I am aware of such an organization, HealthPartners. Ron, thanks for the question. I know there are other organizations, definitely. In fact, my partner in health equity, Dr. Yang, she's definitely more well-versed to answer that. But the answer to the question is absolutely in addition to HealthPartners. But what we've done here, we've incorporated this into our required code of conduct training And we've had series on unconscious bias and recognizing bias. We're also going to be implementing a clinician curriculum as well. So again, we're trying to be about it and not just talk about it. And sometimes you have to be intentional, and it's not real until you write it down. So when you create curriculum, and sometimes if you require it and you set the standard of this is what we expect from those that are going to be a part of this organization, now you can begin to move the needle. Now, you're not going to have everybody excited about doing a training, or again, you have those that maybe say, why are we talking about this? But it's all about setting the standard, like you said, Ron, in your question, and setting the example of, who you want to hire and how you want to, create the culture that you work in and thrive in. So, yeah. And again, Ron, like the other questions, we can definitely talk more offline about that, because I can give you some more information that's not available to me right now.
And if you want to send any resources to Dan, then he can email the group as well, if you have any resources that you think would be good to share.
Yeah, I appreciate the questions. The last thing I'll say, and I kind of said it in the talk, I alluded to it in the talk. I think this thing that we're discussing today, I think it's everybody's job. You don't have to be a subject matter expert, but even as a leader in your department, you just have to be just cognizant of who you're leading. And if we're not comfortable talking about, some of these tough concepts, then how are those that we lead in our departments, how are they going to be confident and comfortable talking about it? And maybe as a result, they won't feel heard, and maybe it'll lead to them leaving the organization. Trust me, it happens. And so, because the world around us is evolving, we as a healthcare community need to continue to consider how we can continue to evolve as well. So that's the last thing I'll say.
Thank you again, Dr. Jackson. If you wouldn't mind switching to that last slide.
Yes, I will do. There we go.
Thank you. Get the Q&A out of the way here. So thank you all for attending today's grand rounds. It looks like we answered everyone's questions today, but if not, please feel free to reach out to Dr. Jackson if you have any follow-up questions. The recording of the webinar will be posted soon on YouTube, and there's a link to our YouTube account on our MinSCIMS website. As a reminder, please see the chat for information on how to obtain CME credit for attending today's webinar. At the end of the webinar, a brief 3-question survey will pop up on your screen. We would appreciate your feedback. We also hope you can join us for our next grand rounds on Thursday, December 1st at noon Central Time, where Drs. Voss, Draper, Olney, and Morrow will present individualized pressure injury prevention, harnessing the power of pressure map data across multiple contexts. Thank you to everyone. Thank you, Dr. Jackson, again, and have a great rest of your day.
Take care, everybody.